Comfort and pain management. The objectives for this unit are to define pain and describe neural mechanisms of pain and pain management, describe legal and ethical issues of pain assessment and management, differentiate between types of pain and terminologies used to describe pain, describe the types of pain assessment scales and their use in pain management, discuss addictions in hospitalized patients, and discuss pharmacological and non-pharmacological pain management. For this audio recording, I basically want to go over the concepts of and definitions of pain and basically the physiology of pain and some types of pain. So first, just by definition, we know that Margot McCaffrey, who's kind of the nursing guru of pain management, says that pain is whatever the client says it is, whenever they say it is, wherever they say pain is. I went to a pain assessment or pain management class, and Dr. Michael Howard, who had researched pain, defined pain as an unpleasant sensation occurring in varying degrees of severity as a consequence of injury, disease, or emotional disorder. So that gives us the picture that pain can have a physical response. It can have physical. An emotional condition can cause pain. It's kind of like that commercial that was on a while back that says, does depression cause pain, or does pain cause depression? Yeah, exactly. Cognitive, how we think and feel about pain, and pain is considered to be a subjective, well, let me say this better. It has a subjective source. In other words, the best assessor of the pain is the person. It's difficult for anybody to assess or understand someone else's pain. It's very, very subjective. Pain is difficult. It's difficult for the person to express and to get empathy. Sometimes people, it would seem, act in more pain or act like they're in pain just so they'll get someone to believe they're in pain. So, man, it's tough how to communicate it. And I loved how your book really emphasized the fact that if nurses don't manage pain and don't become sensitive to a person's pain report and underestimates their pain, that shame on us for that, because who else is going to be able to support and get them the relief they need, especially in the hospital setting? So that means we've got to understand pain and understand resources that we have to help alleviate pain. Pain is a topic of conversation all the time in hospitals. I was just at a meeting last week and pain came up, and how challenging it is to manage, because doctors don't want to be given out or abusing their power of giving out opioids, so that's abused, and yet people need pain relief, and pharmacists being good resources and helping train and teach about pain and how medications, medicinal resources work. And it gets complicated out there to manage pain, but that doesn't eliminate the need for us to understand pain and to respond to a patient's report of pain. So what is pain? Let's look at the physiology of it. There are basically 4 stages of the pain response that have been identified. We don't necessarily feel or recognize each of these stages. Think of the last time you had pain. You kicked the side of the door, stubbed your toe, or burnt your finger or something. It just hurt, and you didn't think about, oh, pain has been initiated. Oh, it's traveling up my arm. Oh yeah, going through my spine. Oh, my brain got it. Yep, coming back down. No, we don't do all that. Bam, we just have pain. And so how does that work? Well, let's understand it a little bit, because that'll help us understand why certain treatments work and where they stop that conduction of pain, and why so many different mechanisms can be useful and powerful for the client. All right, the first stage of pain, transduction. It's initiated with some thermal, so something hot, cold, maybe a chemical, the inflammatory process, or even a mechanical cause, a trauma. This initiation is often referred to as a noxious, like obnoxious, but a noxious stimuli creates pain. And that pain message is received by nociceptors, which are peripheral receptors that respond to whatever the stimuli. That's where the message begins. When the threshold of perception for pain has been reached, when there's injured tissue, it's believed that the injured tissue releases chemicals that excite or activate these nerve endings. So chemicals begin to come out, but transduction is the initiation of the pain response through the nociceptors. Nociceptors are interesting. I just want to give you a few fun facts about nociceptors, just in case you're ever on Jeopardy or anything. Nociceptors are nerve endings that receive the energy or stimulus that initiate or transmit the pain sensation. There are specialized free nerve endings that act as the sensory receptor that responds to pain. Just as kind of a fun fact, nociceptors can measure up to and greater than 3 feet long, and they terminate in the dorsum of the spinal horn. It's been noted that there are as many as 1,300 nociceptors per square inch of the skin. We're loaded with them, loaded with those nociceptors that transmit the pain message. When we're looking at this picture, I put the picture on 2 of the slides here. See where the nociceptor, or the noxious stimuli, then goes to the beginning of this nociceptor. And then it travels up this fiber, which we're going to go now to this idea of transmitting or transmission of the message of pain. Transmission is facilitated by neurotransmitters. There are a number of neurotransmitters, but prostaglandins are one of those type of transmitters. Prostaglandins are hormone-like substances that send additional pain stimuli to the central nervous system. Serotonin. Serotonin is a hormone that can act to stimulate smooth muscles, inhibit gastric secretions, and produce vasoconstriction. Substance P gets talked about a lot in this message. I think of substance P as the glue that connects the message of pain in the dorsal horn, so that once the message has traveled up the nociceptor and it's received by the spinal cord, it helps make that connection. Substance P sensitizes the receptors on nerves to feel pain and increase the firing of the message. Substance P connects the afferent nerve message with the spinothalamic tract to continue the message to the brain. I guess that's where I kind of got that idea that it's kind of like the glue that connects the message there in the spinal cord in that synapse. The transmission of pain is considered an afferent system. In other words, it's taking the message from the nociceptor to the brain. That's the afferent tract. And it travels by way of 3 different nerve fibers. There's the A delta fibers, which are the myelinated smaller fiber that sends a sharp pain message to the brain. So when we're asking patients, is your pain sharp or dull or achy? This helps us understand which fibers are carrying the message. The C fibers are the larger unmyelinated nerve fibers that carry the message a little bit slower, and they carry the achy, throbby type message. I think of the A delta fiber, the nerve fiber, the myelinated fiber, as myelin being that phospholipid, that slippy slide, if you will, of transmission that helps move that message along. The A beta fibers are going to be important later, and see how they're at the bottom of this little diagram here. And the A beta fibers carry normal sensation. So if you just touch your hand with your finger, you feel the touch. If someone massages or rubs that skin, it just feels that normal sensation, and that activates the B fiber. Normal sensation. This is important later because the A beta fiber is a large fiber. A beta, big fiber. Just keep that in mind. That'll make sense in a few minutes here. All right, so this is the afferent system that's taking the message from the point of transduction where pain was initiated. Then it transmits the message to the spinal column where it goes to the dorsal spine and travels up to the brain, in which then the message of pain is perceived. The perception of pain is twofold. It is the sensation, the awareness of the sensory stimuli in the brain. So the brain makes us aware. We sense that pain is there. And then the perceiving of pain is making a meaningful interpretation, a conscious awareness or understanding of the feeling. And so it is then perceived. With perception, there's the somatosensory cortex that identifies the location and intensity of pain. So that helps us when we're asking, can you give a quantity, a signed number to the pain from like 1 to 10? That's our brain's perception of it. And the association cortex, the outer layer of the brain, determines how we feel about the pain. And then the limbic system translates the emotion, the anxiety, the reaction to pain. The hippocampus is really the memory of pain, how we remember it in our minds, and the amygdala is how we feel about pain. Interesting, again, just a little side note when it comes to this limbic system and the understanding of that. The hippocampus remembers pain, and for females, the hippocampus is a little bit larger than the male hippocampus. As far as the amygdala goes, which is the feelings, how we feel about pain, the male amygdala is bigger than the female amygdala. I just thought you might want to know that. All right, so pain has then been perceived, central nervous system, and then in the brain, modulation occurs, and this is the descending nerve response to the pain, the system of modulation of pain relief, and that happens through the process of endorphins, or endogenous, inside, we make it ourselves, opioids. So endorphins is one category of internal opioid, the most powerful being the dynorphin. Enkephalin, another sort of internal opioid, our own internal morphine. Serotonin is a type of endorphin or neuromodulator, I guess that's a better word for it, that helps relieve pain. And then even our norepinephrine system helps modulate our pain response. So this descending system is the efferent motor nerve fibers, those that come down from the brain and then go to and respond to the periphery, the location of the pain itself. So our afferent system sends the message of pain to the brain. Our efferent system modulates and tries to give relief to the pain. Enkephalins, interestingly, are thought to reduce pain sensation by inhibiting the release of substance P, that glue at the terminals that will help then break the sensation and that message of pain. So that's the physiology, these 4 stages or 4 processes of pain. There were some doctors back in the 60s, Melzack and Wall, who wondered, is there a way that we could treat pain without using medication? And the long and short of the history lesson is they discovered what they called was a gating mechanism along the central nervous system. They discovered that those A beta fibers, remember those large fibers, big fibers, A beta, big, large fibers that just sense normal touch and warmth and cold, if they could be stimulated, they would block the message of pain that was being sent by the smaller C and delta fibers. So when you look at this picture here, what they're talking about, again, I don't know if you can see my little mouse here pointing, but if we could stimulate this large fiber and it would come here to the dorsal horn, would it stop or block the message that was being sent by the myelinated and unmyelinated delta and C fibers? And so they discovered that indeed it could help relieve pain. And so you could stimulate the large fiber, the beta fiber, by heat, warmth, or by ice, or by electrical stimulation, or by massage. I think maybe the easiest way for us to relate to this gating method is that if you hit your finger with a hammer, and like you're nailing or something, and you hit your finger, what do? You rub it, because you want to help get rid of that pain, and that's stimulating the B fiber, which is helping block that passageway, that conduction of the pain fibers. When mom rubs a child's sore little boo-boo and kisses on it, they're really, they're being a wonderful mother, and they're also, maybe unknowingly, they were stimulating those B fibers to stop that pain message. What's important to understand, and a term I want us to kind of get our head on at this point, is then what is someone's pain threshold? Pain threshold is the point at which someone feels pain. And that can be different for a lot of people. You may feel a pain of 10 differently than I might feel a pain of 10. And conversely, we both might feel our pain of 1 differently. When do people feel pain? When are they uncomfortable? And that's important for us to begin to recognize. Client responses to pain are twofold. There's a physiologic response. The body responds to pain, and that's really through our autonomic nervous system, the ANS. There's the sympathetic response and the parasympathetic response. The sympathetic response is our fight-flight mechanism. That's when pain is maybe in its acute phase, it's at its peak, and the central nervous system, that sympathetic branch, causes the dilation of the bronchial tubes, increases respiratory rate, increases heart rate. There's peripheral vasoconstriction. That's why people get white and their blood pressure goes up. The blood glucose levels come up. It's that fight flight, that quick energy they might need to get away. People get sweaty, increased muscle tension, pupils are dilated, they're on alert, decreased GI motility, increased energy, oxygen intake, muscles are prepared for action, there's better vision, it frees energy for more immediate activity. If the pain is continuous, severe, or deep, typically like involving the visceral organs, the parasympathetic nervous system will have to eventually come into action. You cannot live in a sympathetic state. It's exhausting. So the parasympathetic comes on board, and it decreases the heart rate. It decreases muscle tension, decreases the blood pressure. It slows breathing, maybe even an irregular type breathing. Things slow down, and so that's the sympathetic response. What's interesting for us and we've got to understand this and appreciate it, is if someone is in chronic pain, they have already processed through the sympathetic system. They can't live in that state. The parasympathetic has modulated the pain, and now they're just living with it. So they're not crying. They're not moaning and groaning like someone that maybe just broke their leg and is in an acute state. And so that's why people tend to, and I'm talking people like nurses and maybe family members are like, you can't be in that much pain. I mean, you're not crying. Your pupils aren't dilated. Your pulse isn't up. No, not even a fair system of report. How many of you have come to class, even in these few weeks, with a headache? Girls with menstrual cramps. We come, you guys look fine to me, right? We come, we put on our happy face and everything's fine, or maybe we're not as energetic, but we do life. Did that diminish the reality of the pain? Absolutely not. So we've got to be sensitive about that. There's also a behavioral response. How do people respond to the pain? How do they report the pain? How are they preventing the pain? Are they guarding? Are they being stoic? Are they denying the pain, ignoring the pain? What's happening for their as far as a behavioral response? Sometimes I'll see a patient maybe right after surgery, and you know they've got to be miserable. They just had surgery, or the day after when anesthesia has worn off, and they're like, oh no, I don't have any pain. I'm fine. And I'm thinking to myself, is that even possible? Right? So maybe a culture or gender or something is causing them to be more stoic and, oh no, I'm fine. I can handle it. But there's a lot of physiological consequences to pain and how the body responds. So that leaves us with this other idea of then what is somebody's pain tolerance? Their level of pain that they're willing to put up with. Some people have a low threshold and they might be labeled as whiners. If someone can't take as much pain as you can, for example, then, oh man, what a whiner, what a weakling might be our thinking. When in reality, it's just they have a lower pain tolerance than someone, like I mentioned, maybe that had surgery. And honestly, I would be whining with that kind of pain or that kind of intervention or treatment, and they're being fine about it. What is someone's pain tolerance? Some behaviors that you might see people doing that give you an idea that maybe they're having pain is they might be clenching their teeth, holding the painful part, maybe a bent posture, grimacing, crying, moaning, restless, frequent requests of the nurse, irritable, demanding, unable to please. All of those might be behaviors that people might have. Let's just be honest. Pain hurts, right? And if you've been putting up with it, there's just not a whole lot of us that want to have pain in our lives. Pain has some good qualities about it and some negative qualities. And the good quality of pain is that it's protective. It causes us to seek intervention. And so for that, pain is good. And it helps us to treat people and attend to something. Pain has a physiological quality about it, and we need to take it seriously. All right, what are some types of pain? Just as a basic review, let's just go over some definitions, and you certainly can be looking at those. And oh, pain. Acute pain. Acute pain has a, like I mentioned earlier, one of that positive qualities is that it's protective. It has an identifiable cause, and usually, because it's acute, it has a short duration. When we think of a short duration, you might see terminology that says the pain doesn't last more than 6 months, but a more accurate definition would be that the pain is commensurate with whatever the injury was or whatever the noxious stimuli. For example, if you get a paper cut, right, all those nociceptors that got involved from a little slice on your finger, and it hurts bad for a few minutes, but it shouldn't hurt for 6 months. That would be inappropriate. Surgery pain. most of the time with acute pain, it will eventually resolve with or without treatment after that damaged area heals. But sometimes recovery will be speedier if pain can be relieved. Acute pain has a predictable ending or healing and an identifiable cause, and this usually results in a willingness by the health team members to treat acute pain aggressively. It's important to realize that unrelieved acute pain can progress to chronic pain. And acute pain can threaten the recovery of a person by resulting in prolonged hospitalization and immobility. And so that's why it's so important that we treat it. Chronic pain lasts longer than anticipated. It may not have an identifiable cause, and it leads to great personal suffering. Sometimes people don't even report it because it's become their normal, and they don't even realize they've been putting up with it so long. It just is what they put up with. I was talking to an acquaintance recently who has a family member that's been in chronic pain for the last 25 years, and they are constantly at a 7, constantly 7 out of 10. Can you just imagine living with that? And you can't live with that and just always be grimacing. People go on with their lives, but that doesn't nullify the idea that they have pain. Within the idea of chronic pain, we need to understand that there's a difference. There's a couple different types of chronic pain. Nociceptive pain is normal pain. It's when those nerve endings have been sensitized because of some kind of noxious stimuli and they respond normally. Someone has surgery, that's nociceptive pain. Someone kicks the door jamb by mistake, you know, and that's nociceptive pain. But somebody whose nerves are damaged by disease, illness, cancer, have chronic pain, and that chronic pain is very complex. The nerves are damaged, and thus they report burning, tingling, numbness, or shooting type pain. There are a number of different kinds of neuropathic pain. There are paresthesias, abnormal sensations and tinglings. There are dysesthesias, which are unpleasant, abnormal sensation. Allodynia, which is pain from a stimulus that doesn't usually evoke pain. So an allodynia, or dynia, A-L-L-O-D-Y-N-I-A, someone takes a wisp of a cotton ball and swipes it across their arm, and that causes severe pain. That's nerve damage. Hypoalgesia is decreased pain, where hyperalgesia is an abnormally painful sensation or exaggerated pain. All right, and so those terms usually fall within this idea of chronic pain and neuropathic pain. There are two other kinds of pain we want to know the difference between, and both of these fall within the idea of nociceptive pain, normal pain, and that is somatic pain, which is musculoskeletal pain, so the ligaments, bones, joints, muscles, or connective tissue. And somatic pain is usually achy or throbbing, and it's well localized pain. Whereas visceral pain is in the internal organs. I mean, think the body cavities like thorax, abdomen, brain. And those are types of pain like you would have crushing pain with angina, so the heart, burning pain with a gastric ulcer, or sharp pain with gas in the bowels, so visceral pain. Cancer pain is pain from pressure on nerves and organs, or maybe even blockage of blood supply related to the cancer overgrowth of cells. It can be a rapidly progressive disorder, and very often can be chronic. and we're treating something that's not going to go away for maybe the rest of their life, depending on the cancer and if that has been resolved or not. Superficial pain is from the surface areas such as the skin or mucous membrane, and vascular pain is from vessels, perivascular tissues, maybe pain that contributes to headaches or migraines is considered a vascular pain. Pain expressions, or some pain terms. Radiating pain is a sensation of pain that extends from the initial site of the injury to another part. Maybe someone says, oh, the pain just goes down my leg. That would be sciatic pain. The sciatic nerve, maybe from the buttocks area, and it radiates down the leg. Referred pain is pain that is felt in a body, in part of the body, separate from the source of pain. So it's in a completely different area. And it can assume any characteristics. So maybe someone's had a myocardial infarction, they've had a heart attack, and the pain is in the jaw, or the pain is in the arm or shoulder. Kidney stones. Your kidney stones are right there under the base of the rib area, and yet people might complain of pain in the groin, so it's referred. Intractable pain is highly resistant to relief. They need to use a variety of methods to relieve pain. Phantom pain is a painful sensation in a body part that's missing or paralyzed, and it's also phantom pain is considered a neuropathic type pain. So if someone's had their leg amputated from below the knee and they complain that their toes are killing them, well, the nerves haven't made the connection that those aren't toes down there. And so it's a phantom pain. Still pain. It's just the brain's registering it at a different part of the body. Idiopathic pain is chronic pain in the absence of an identifiable physical or psychological cause, or pain perceived as excessive for the extent of organic pathological condition. So let's just put that in English. You get a paper cut and you rate the pain as 10 for 2 days. Wow, that's idiopathic. That doesn't make sense. Neuropathic pain is considered a burning type, shooting, or electrical. And again, it's a complex pain related to nerve damage, not just the regular or normal conduction of pain from the nociceptors. And that's it. Well, that's not it. That's all we're going over because we have so much more to cover as far as how we're going to assess and manage pain. So if you have any questions, bring them to class.